Okay, well, why don't we go ahead and get started? Greetings to everyone. I know that there are some who are just joining us, but it's wonderful to see so many of you here already for our Education Committee satellite session. On behalf of the organizing committee, Iris, Sylvia, James, Diane, and myself, I just want to welcome everybody who is joining us this morning. I'm going to hand it over to my colleague and co-chair with me of the Education Committee, James Hudspeth, to take us through the agenda for our morning.
Well, welcome everybody. Thank you, Tracy. So we have a very packed agenda, and I think one of our challenges, as always with this satellite conference, is trying to get through a lot of things over the course of 3 brief hours. We're going to open up with about half an hour of hearing from some of the education subcommittees and working groups. These are really the workhorses of the Education Committee, and as you'll hear, they're doing a lot of the projects that help push forward the global health agenda that CUGH and our member institutions are trying to achieve. This is also an opportunity for those of you who are less familiar with the Education Committee to hear a bit about what we do and to hear about potential places you might want to get involved going forward. After that, we're going to shift to the hot topic presentations. So these will be recorded videos of presentations dealing with particularly interesting topics in global health education that were selected competitively. And during that process, we'll have the ability to do Q&A in the chat, and then we'll end with a few questions done verbally live. We'll have a very brief 5-minute break, and then we're going to shift into 40 minutes of roundtable discussions. There'll be concurrent breakout rooms. You'll be allowed to select which topic interests you the most, and then the organizers will be walking through some areas of interest to them and trying to get feedback and participation from the audience on that topic. We'll have a very brief report back from the various roundtables, and then we'll have a similarly very brief conclusion. And I'll just plug throughout this, like we really want people to be involved. Last year, the chat was a really powerful way for people to post questions, raise other resources they're aware of, and generally engage with one another. So we're really hoping that will be the case this year as well. Feel free to put anything in there that you would like, and then we'll also be sharing contact information for a lot of the presenters at the end of this as well.
Okay, so we'll just start off. I'm going to show a compiled video with the updates from the different subcommittees and the working group as noted. James is also going to be putting a link in the chat to the annual report that we submitted on behalf of all of our subcommittees and the Education Committee to the CUGH board just in January. So that'll give you some additional information about what's going on with each of these groups. So let me switch over to the video and we'll get started.
Hi, my name is Carlos Alberto Fayron Guzman. I am the chair of the Competency Subcommittee. I'm speaking on behalf of everyone on the subcommittee, as well as Barb Assel, my endeared co-chair. So for us, it's a bittersweet presentation because it is our last presentation as chairs, as I want to congratulate and transition the leadership of this subcommittee to, and hopefully you'll join me in congratulating Dr. Deli Augustentine and Dr. Paula Davis, who just got voted in as the new co-chairs and will be leading this process in the next couple of years. So I'll skip to our accomplishments of our last year. This is, as you know, most of our work revolves around the competency toolkit, and it's an ongoing work to be updating it. And that was a work that was led by Amy Moore from our subcommittee. We also had approvals of 2 abstracts for this conference, so we're looking forward to seeing those in action. And also we are participating and we are part of the subcommittees that we're proposing a satellite session on decolonizing global health. That satellite session, of course, I think by now would have happened or will be in the near future. There's the other aspect of our work that also revolves around the Planetary Health Education Framework. That is a work that we do in collaboration with the Planetary Health Alliance. And in that vein, we had a framework webinar where we introduced the webinar to the CUGH community in August 2021. you can probably still find that webinar on CUGH website. There were two other big buckets of work. Some of the subcommittee members were focused on and were the participation in two special collections that are related to decolonizing and planetary health education. There's a Lancet Planetary Health special edition that will come up in upcoming months regarding education in planetary health. And then there's the Annals of Global Health, Decolonizing of Global Health special collection that was led in continuation of the Global Health Summit held at the University of Maryland, Baltimore in 2020. So look forward for those publications as part of the work or in relationship with the work of this subcommittee. Finally, for the goals of 2021, 2022, or I mean 2022, 2023, I'm sorry there for the mistake in this slide. We hope to integrate I know Delhi is one to really push the SDG framework forward, and I know one of his big projects would be to lead the integration of the SDG framework into the competency framework and mirror those into our education. We also have a group within the subcommittee that is revising anti-racist and decolonizing paradigms and how those might relate to global health education. And then finally, there is a competency toolkit survey that has now been approved by an NRB in Canada, and we're hoping to roll out that survey as soon as possible to get people participating in how they use and what kind of feedback we can get on the toolkit survey. So from me and Barb, it's been a pleasure working in this subcommittee. We hope to continue to collaborate with everyone related to the Education Committee. And as you know, we're both very active in this community, and we hope to continue to participate. So thank you and have a great conference.
Welcome. This is the 2022 Annual Conference Report for the Subcommittee on Master's and Undergraduate Degrees in Global Health. Smudge analyzes curricular trends for undergraduate minors and bachelor degrees, as well as master's and doctoral degrees, identifies emerging innovations in curriculum design, teaching, and experiential learning for global health at the undergraduate and graduate levels, and seeks to make CUGH useful to colleges and universities with diverse institutional missions.
Smudge plays a unique role within CUGH as the only committee focused on non-clinical education. Undergraduate majors, minors, and certificates, and MS, MA, and other academic graduate degrees in global health have different goals than clinical and professional training. An analogy for this can be described using light bulbs. Academic programs study the theory of electricity, develop new types of light bulbs, like LEDs, and examine what light sources are used by different population groups. By contrast, clinical programs focus on how light bulbs are useful for professional practice. Medical and professional schools now prefer incoming students and trainees to enter with a foundational knowledge in global health, so that they are ready to participate in international practice-based education. This shift has increased the importance of didactic and experiential learning at the undergraduate level.
Over the past several years, Smudge has created resources for curriculum design, program development, teaching, and advising in global health. One example of these resources is the CUGH Student Learning Objectives in Global Health, which were published in 2020. The SLOs highlight the core principles and theories of the field and prepare learners to use multiple disciplinary and professional lenses to explore the social, economic, environmental, policy, and other factors that impact population health.
The SLOs provide a framework for holistic examinations of the complex health challenges that affect people worldwide, such as pandemics, climate change, and other events associated with globalization. Smudge resources are compatible with a variety of approaches to global health education. For example, the SLOs apply equally well to colleges that use a multidisciplinary approach to global health learning, as they do to universities that offer specialty programs like global public health or discipline-specific programs like global medical anthropology.
Smudge also seeks to support networking and professional development opportunities for global health educators. One of the ways we do this is through sponsorship of educational workshops. The next Teach Global Health Curriculum Design Workshop will be held in June 2023 at Allegheny College in Pennsylvania. Smudge also supports the professional development of educators through its ongoing partnerships with nonprofit continuing education providers. In-person experiential education workshops in Costa Rica will resume in January 2024.
Smudge resources can be accessed on the CUGH.org website. If you would like to interact with other global health educators and learn more about the work that Smudge is doing, please attend the live Smudge panel on global health education on April 1.
We would like to thank all current members of Smudge for their service, and we look forward to collaborating with the incoming chairs and members in the upcoming year. Thank you.
Good morning, good afternoon, good evening, depending where you are. My name is Teresa Machai Macete. I work at the Health Research Center in Mozambique. It is a great pleasure to present at the Consortium of University and Global Health Conference, the Academic Partnership Program Initiative. This subcommittee has two co-chairs, myself, Teresa, and Barbara from US. The Academic Partnership Program Initiative is designed to connect individuals representing institutions that are interested in creating, growing, or strengthening their global health programs with individuals who have substantial programmatic experience in global health. What we have done so far, the Academic Partnership Program Initiative was able to launch the call seeking participants for this program. The Academic Partnership Program Initiative was able to initiate the first institutional connection to enable sharing of information. This was done with nursing department at Nepal, and the WHO at Nepal has stepped forward to add two 12-week intensive geriatrics courses for nurses in collaboration with Academic Program Partnership Initiative. Target for this current year. We aim to strengthen academic program through Academic Partnership Program Initiative, connect experienced academic leaders interested in strengthening educational programs in biomedical or non-biomedical institutions. So, having said that, I would like to finalize by saying that we expect also to solidify the teaching capacity, geriatric and institutions largely from higher income countries. Thank you so much.
Hi, everyone. We're here today to talk to you a little bit about the Trainee Advisory Committee. My name is Deepika Khanna. I am the current Trainee Advisory Committee Chair. I'm a current third-year medical student at the University of Illinois College of Medicine. I'm based in Chicago here in the United States.
And I'm Elizabeth Frost. I am the chair-elect for TAC, and I'm a PhD student at San Diego State University.
So just to introduce us as TAC, we're a committee of 25 students and trainees of various backgrounds from around the world. This is us, our group from the past Trainee Advisory Committee year. We consist of 5 internal committees. We also participate in other CUGH committees as well. So we're here to talk to you about some of the things we've accomplished in the last year, as well as some of our goals. So we like to look at our goals under 3 sort of umbrella themes and see what we've accomplished and what we're looking towards. So in terms of this first goal is to strengthen TAC internally, as well as its engagement in CUGH activities. Some of the things we did in the past year were develop a mentorship program within TAC to help onboard our incoming members. We also tried to improve our relationships with on other CUGH committees by helping to evaluate the experience of TAC members and improve our engagement. Many TAC members assumed administrative and participatory roles in the 3 subcommittees that were developed on the CUGH Decolonizing Global Health Working Group. And we also worked to improve our campus representatives' communication by surveying them on their preferred communication methods in order to improve engagement. Another goal that we've had is to increase student trainee diversity in terms of ethnicity, academia, and gender. Some of the things that we did in the last year were working to continue diversifying TAC. We really are made stronger the more skills and experiences and backgrounds we welcome to the table. So in the past year, we've expanded our inclusion of trainees from a wider range of academic backgrounds and areas of studies. We're also continuing to track this via demographic metrics. We've collaborated with students outside of TAC from Latin America and Africa on the Global Public Health Workshop Series working group to help create inclusive workshop ideas for students in global health. And then we worked to expand the definition of global health in other languages, including Spanish and Arabic. And finally, under the goal of prioritizing global health advocacy, earlier in 2021, we created a gun control advocacy guide amidst many tragic mass shootings in the United States to help encourage advocacy for stricter gun control policies within the US. We also have been developing an anti-science tracker, conducting a literature review about anti-science and compiling commentary to be published on anti-science attitudes. We created 2 white paper working groups, and they are solutions to addressing climate change and COVID vaccine access and resource allocation. I'll pass it over to Elizabeth to talk about our goals for the next year.
So our goals for next year fall under those same 3 goals that Deepika mentioned. And so under these goals, we want to increase TAC participation on all CUGH committees. We want to connect and collaborate with other student global health organizations, really network and get TAC students involved with other global health students. And we want to promote strengthening of connections among TAC members to learn about the skills and experiences that we all bring to the table. And under the second goal, increasing diversity, we want to promote TAC to a wider and more diverse audience. On the basis of inclusivity, we want to continue tracking demographic metrics on both TAC and campus representatives to identify those successes and areas for improvement. And we also want to discuss accessibility of resources to make sure that everyone has access. And this includes on TAC and campus representatives. And then under the third goal, prioritizing global health advocacy, we want to encourage new advocacy initiatives among TAC members. We want to collaborate with campus reps and other student organizations on advocacy topics and continue to identify important advocacy issues to students globally. And we have an amazing group, amazing cohort coming in this next year that we're very excited for all their new ideas and energy that they bring. Thank you so much for listening. Please feel free to ask us any questions during the Q&A. Also, we will have a breakout panel during the conference and satellite session on March 25th. Please visit our social media sites for more information. Thank you.
Thank you. And if you are attending the conference, you can also stop by our virtual booth for more information.
Hello, everyone. I'm Suraj Bhatrai, one of the co-chairs of Workforce Capacity Building Subcommittee. So here are the accomplishments of our subcommittee in the last year. For example, we continue to support and advance the capacity building resource database and conducted a study to evaluate the impact of the database on partnership development. We also collected feedback from the end users. We submitted an abstract and plan to present the findings at 2022 CUGH conference, and it's a proud moment for us to share that the capacity building subcommittee has been able to secure a funding from the Civilian Research and Development Foundation to advance this idea. On leadership development program, our subcommittee was able to build consensus to develop multidisciplinary longitudinal leadership development program for different categories of global health. And we also invited key global health specialists to brainstorm the ideas. Likewise, our team submitted CUGH panels on leadership in midwifery and also on the global mental health. On the same topic, our team continued to collaborate with colleagues from Sierra Leone to build the capacity of mental health workforce in Sierra Leone. And regarding the capacity building of nurses for geriatric care, our team continued to develop the idea and then also a few collaborations and with the US institutions, but also with the local organizations like Kathmandu University and WHNFL. And finally, we also talked about a few topics. For example, climate and health, which could be a potential satellitization for the CUGH. The targets for the next year are given in this table. So we want to continue these activities, but also consolidate our plans. For example, conducting a phase 2 development of capacity building database with the implementation research focus. And in the leadership development program, we want to seek grants and write a grant proposal on mental health projects. We continue to share the resources to the physicians and psychologists, nurses in Sierra Leone for the nursing capacity building project. There will be formal support from the CUGH and also from the WHO Nepal to Kathmandu University. So once it gets institutionalized, then the project will run smoothly. So we also want to continue on a few other activities like writing opinion pieces, review articles, for example, on the physician burnout, rural physicians, and the factors affecting the postgraduate trainings. So thank you very much.
Hi, my name is Dr. Jenny Benziger. I'm the Associate Director of Education for the Center for Global Health here at Indiana University. And together with Sharon Clark, we lead the GME working group. In the past year and a half or two, we have been working on what we call GHEART, which is the Global Health Education and Resident Training Curriculum. First, so our goal has been to create a foundational global health curricular outline for medical residents of at least moderate interest in global health that could be used by all specialties as a core. These would be residents probably that are in some sort of global health track or fellowship. And our goal has been to answer the question, what should these residents and fellows really know, to which they could add specialty specific information onto. So we created an outline, a curricular outline. We matched it to the ACGME core competencies. And we have determined that it would be ideal to cover these topics in about 20 to 40 hours, sometime during the person's residency or global health fellowship. Like I said, specialty specific information would need to get added onto this. So for example, if you were doing an ophthalmology global health residency, you would cover these core topics and then you would learn ophthalmology specific information in addition to this. This is just a sample of the curriculum itself. So it covers topics like the basics, defining global health, differentiating it from infectious disease, global health professionalism, cultural humility, demonstrate cultural sensitivity, identify resources for working in unfamiliar settings, and then broader topics like the social determinants of health and health disparities, down to the ethics of global health, being able to identify ethical guidelines, summarizing topics of research ethics, not necessarily delving into research itself, but just knowing what would be involved in being an ethical global health physician. This is just a sample. Our curriculum had 8 different topics, and these are the ACGME competencies matched to each one. This past year, we surveyed global health educators. So 59 global health educators from 29 institutions evaluated this outline. 96% felt that the topics were at an appropriate level. 88% felt like the learning objectives were clear. Overall, got very positive responses back. The highest yield topics were more of the basic topics, so defining global health, the social determinants of health, the ethics, and then if we lower a little bit on the list, we're covering things about global health interventions and global health systems. Certainly not unimportant, but if you had to prioritize, this is what they had suggested, what we would prioritize. So for our goals and our next steps over the next few months to year, we would love to get more feedback on our curricular outline. We would especially love more input from specialists and partners in our low and middle income countries. We recognize that we need to know what other people think our residents here in the US need to know about. So we need more input. If you have ideas or suggestions about who we should ask, please send them my way. And then we'd like to start fleshing out the curricular outline itself. We know we don't need to recreate the wheel. There's lots of good resources out there. So we plan to collate a list. And if there are gaps of things that educators have said that learners need to know about, we would develop any extra resources that haven't been shared widely. So we also would love to partner with other CUGH subcommittees who are covering key topics, big areas like decolonization and pre and post departure curricula, which feel separate in that they're a little bit independent topics in and of themselves. And then lastly, working on just disseminating it and getting out to the educators that will hopefully be helped by our curriculum. Thank you. If you have any questions, don't hesitate to reach out.
Great. So, so as you can see, our committees, our working groups have been very active, and we have a very diverse array of projects, topics that everyone is working on. So as noted, please put any questions that you have for our committee and working group chairs, please put them in the chat. We had hoped to have some space for a live Q&A, but I think in the interest of getting through the rest of our session, we'll just go ahead and keep moving on. So let me put up our agenda for the hot topics portion of our session. Okay, so we have 6 hot topics presentations that we're going to be doing. So I just wanted to give you a sense of the sequence for the next portion of our satellite. So first, we'll be hearing about building equitable partnerships, capacity development of Indigenous organizations for equitable and effective development collaborations from Clive Anderson and Shreth Mwandia. Then we'll hear about clinical performance evaluations of resident physicians using a competency-based framework in China from Shan He. This will be followed by a talk on practicing beyond one's scope while working in low and middle income countries by Jeff Hartman and Kripa Dolakia. And then a session on undergraduate intercultural competencies in a multi-ethnic country by Claudia Ortiz Rico. And then our remaining 2 hot topics will be entitled Towards Decolonizing Research Methods Training, the development of a locally responsive online learning course on research methods for mental health in war and conflict for researchers and practitioners in the Gaza Strip by Nancy Tamimi and Hala Khalawi. And then our final hot topic session will be entitled Virtual Global Health Education, Impacts on Learners, Organizations, and Equity by Jessica Everett. So I'd ask everyone, please put your questions in the chat as we go. Our presenters or their colleagues are all online and will be available to answer questions in the chat. And then my colleagues, James and Diane, will be monitoring these questions and we'll select a few for the live Q&A discussion portion at the end of the presentations. So let me move us forward to our first hot topics presentation.
So my name is Clive Anderson. I'm from Kingston, Jamaica. I'm a clinician, and I was previously country director for the ITEC local office, ITEC being the International Training and Education Center for Health here in Jamaica. And we were responsible for activities in the Caribbean to build the capacity of healthcare workers and to improve the services, the processes on which these healthcare workers toil. Yourself?
So Clive, my name is Shresht Mawandia, and I'm the project director for ITEC Botswana based in Gaborone. Originally, I'm from India, but I have been living here for the last 6 years. Currently, I plan, manage, and oversee the implementation of ITEC's PEPFAR-funded project activities in Botswana. I have extensive experience in development, implementation, and evaluation of public health projects in Asia and Africa.
Fantastic. You're eminently suited then to discuss the topic as we go on to talk about equitable partnerships. Sure, I don't know if you have a definition that you like.
So Clive, I think from my understanding, equitable partnerships are characterized by mutual responsibility, mutual respect, and inclusion in global settings. So be it an international organization or a local organization, an equitable partnership would be both the organizations or a donor or a recipient have those key pillars of respect, responsibility, and inclusion. What do you think, in your opinion, is equitable partnership?
Yeah, I think you've summed it up pretty well. I would add to that only a respectful and continued sort of communication between these partners in order to make it equitable. I thought a little bit more, Suresh, about how to achieve that. I mean, I think your definition is spot on and it really encompasses what I was going to say. But how is that achieved in practical terms? And I think the changes that have to be made are deep, and they have to look at how funding decisions are made and where those funding decisions are made, how local stakeholders are brought into the process of making, of informing, of implementing, of course, these funding decisions. I think that we have to look at developing structures and processes that allow this sort of respectful, continued communication around this to occur. And that there has to be a move away from short-term funding, I think, which I think leads to inequity. It promulgates that, it sustains that sort of inequity. And so this sort of short-term funding with short-term wins and low-hanging fruits what we're trying to achieve in terms of output in the short term, I think leads and strengthens that inequity, and we have to move away from that. And I think it requires a power shift, a shift in the basis of power, really, away from where it now resides to ensure it's more equitable, and that some of that power also resides equitably in what's termed the global south.
Yeah.
So
yeah, spot on, Clive. And I do think these partnerships are significant, and they are beneficial to all the parties involved.
Indeed.
These partnerships, they bring ownership, they strengthen institutional capacity. They also provide long-term sustainability and efficiency and improve the overall development and overall health systems outcome. And
I was going to say that we're speaking the same language. Please go ahead, finish up.
Yeah, and I really liked your input on the implementation or how to actually make it happen. So while everyone seems to agree with it in principle,
right,
the actual practice, I still think implementation is quite difficult. And I would still say the high income countries, they usually are in the driver's seat, and either be with control over the funding or the initiation of these partnerships or the management of global health programs. And that's why I think the continued discussion that we are having about the successes and challenges and how to make this happen are important. And through these dialogues, I'm hoping that the equitable partnership actually happens and doesn't just end up being a buzzword in global development or global health picture.
Indeed. And I think one key way to ensure that this does occur, it does happen in practical terms, is to build the capacity of local or indigenous organizations. That is key. And we often hear that these organizations are not sustainable, they don't have the expertise, they are judged to be inadequate. And sometimes they are, but how we judge that sort of adequacy and capacity, I think, favors the sort of Eurocentric model, to use that hackneyed term, where we look at things from a point of view that is, I want to say colonial, but that may be being a little harsh. Maybe I should say international, and which doesn't use a template that is applicable for these organizations. And I think that in judging the capacity of local organizations and local persons, many of us make that mistake, and I include myself as a product of higher learning from the North, and that we really need to value more the learned experience of our peoples.
Yeah, absolutely, Clive, absolutely. And I agree with you. And I do think in the same lines that you suggested, I think the biggest misconception is looking at the capacity of all the lower or the middle income countries through the same lens. And again, for lack of better word, I would say the Western centric or colonial lens. And then, at times we measure this through unrealistic indicators. And I think that measurement of capacity is unfair. So say, for example, some Southern African countries, they fund over 90% of their health budget. So I think the measurement standards needs to change, and donors need to develop the courage to take the chance and invest in local actors, and foremost, stop assuming that there is lack of capacity and expertise at local level.
Indeed, indeed. And in addition, I think that the donors, the institutions largely in the global north, need to partner more locally with institutions of learning and knowledge production locally, and not just in terms of sending graduates or undergraduates for a short period of time, but so that the structures here can be built so that local persons can remain here and have increase their knowledge, increase their learning, and contribute their expertise locally.
Absolutely, Clive, absolutely. And let me share recent example that comes to my mind, the COVID variant Omicron. So when the scientists in South Africa and Botswana announced that they have sequenced new and potentially more contagious variant of COVID-19, the EU, the US, the UK, they immediately imposed travel ban. Now, the scientists now know, while the Omicron variant was indeed first detected in Southern Africa, it did not originate here or may not have originated here. I think excellent science should be applauded and not punished. Just
Indeed.
because the science came from here doesn't mean it should be punished. And instead of lauding the scientific achievement, the world punished South Africa and Botswana for its advanced genomic sequencing and the ability to detect newer variants quicker.
Yeah, and unfortunately, it wasn't just the global north that did that, but some of us, our countries in the south, were pretty quick to impose these bans too, and to even question the science around whether indeed this variant was milder, and some of the reasons why. So yes, it's pervasive, isn't it? Yeah. I wanted to give an example. Well, two things come to mind. Firstly, I think it's important for us to note that there are institutions that are working to build this equity, to ensure that local capacity is understood, not underrated, but preserved. And I hold ITEC up as an example of this, where in the aim of ITEC is not just to build capacity in its locals, but also to build institutions that are sustainable. Yeah. And in fact, over the years, ITEC has spun off what we term baby techs in many countries, including your own and mine. And importantly, though, they worked with us to build not just administrative and governance and finance structures, which were strong and sustainable, but ensured that there was funding, which is critical for any startup that allowed these baby techs to flourish, at least in the short term, and to ensure that they had a future. So that I think is laudable and an example of what can be done. I just wanted to finally say, Shreya, that COVID-19 has increased these inequalities. And I think there has to be a role for global health in looking at what happens to our healthcare workers, not just building their capacity here, but we in the South and in the Caribbean, for example, lose 2/3 of the healthcare workers that we train to the global North to work there and to contribute there. And we're happy for their success, but it drains our health systems and creates greater inequities. And so I think global health has to find a way to tackle that critical problem.
Yeah, spot on, Clive. I 100% agree. And I do think the conversations like these that we are having at these international forums would definitely contribute towards addressing that.
Indeed. I look forward to further discussions and perhaps further partnerships, Sherez. I think that we are guilty ourselves in the South of not building those South partnerships that can play a critical role too.
Yes, absolutely.
Thanks, I've enjoyed this.
Me too, and thank you, Clive. And for participants, we are open to questions, comments, and your inputs. Thank you.
Have a great day.
Wow. Thanks so much, Clive and Shreth, for that fantastic presentation. I'm loving the discussion that's happening in the chat. So I encourage folks to continue with that as we get things ready for our next presentation here. Hang on just one second and I will share that with you.
Hi, everybody. My name is Sean He from the University of Chicago Medicine, and together with Dr. Rensla Scher and Dr. Jonathan Leo, we're excited to talk with you all today about using a competency-based medical education framework in order to evaluate residents at a residency program in China. To set the stage, residency education as it currently exists in China began in 2013 when China first launched the nationwide 5+3 standardized medical education, which consisted of a 5-year undergraduate and combined medical school training, followed by a new 3-year standardized residency program. Challenges in implementing this residency included integrating the varying programs that had existed prior to this establishment, which varied greatly in terms of requirements needed for certification. Another challenge being with all these new standardized residency programs being able to ensure quality control. Our project works with Zhongnan Hospital's residency program affiliated with Wuhan University in China. They created their standardized residency program in 2014. And in addition to meeting national requirements, faculty at Zhongnan worked together with faculty at University of Chicago to also create a competency-based medical education framework, which was one of the first of its kind at a residency program in China. In creating this CBME framework, special care was taken to ensure that the specific healthcare and cultural context of China was considered in this being one of the first frameworks of its kind. This was accomplished by querying faculty at Zhongnan to understand what are the most important competencies and values that are essential for a physician to practice well in China. This resulted in a framework with the 5 core domains outlined on the left, with professionalism at its core, along with patient care, communication and teamwork, scholarship, and quality assurance systems as the 5 core domains of this framework. In addition, one feature of China's healthcare context that became very important to the study was the presence of 3 different resident types at many residency programs in China. I'll first start from the bottom of this table with regular residents, which are analogous to typical United States medical residents. They have finished a 5-year combined undergraduate medical school program and are now signed on for 3 years of a clinical residency, after which they will apply for jobs across the country. The second kind, master's students, have also finished the 5-year program, but are now signed on for a concurrent clinical residency and master's degree, which involves classes as well as working towards a master's thesis. This also takes 3 years, and afterwards these residents will also apply for jobs across the country and tend to enter more prestigious institutions. The third kind, called the hospital faculty track here, are residents who have finished that 5-year program but have also finished a master's or doctorate equivalent degree in medicine. They do clinical duties as well as research during their time in residency, which lasts for 1 to 3 years, and afterwards they are already contracted to remain at Zhongnan Hospital or their training hospital as faculty members. Presently, this CBME framework is fully implemented at Zhongnan Hospital's residency. It consists of monthly evaluations that attendings will fill out on the performance of each resident in each of the core competencies. Our aim was to take this data and to analyze the resident performance on each competency domain, as well as to find trends across the 3 years of residency and the 3 different types of residents that are present in this program. In our study, we performed a statistical analysis of all the evaluations filled out with this framework in the year 2018, totaling over 3,000 evaluations. In each of these, attendings graded the residents on each of the core competencies on a scale of 1 to 5. I want to pay special attention to the grading standard 4, which is the level of an end of year PGY3 and thus one that is ready to practice independently. Our analyses were based on the percentage of resident evaluations in each category that met this standard. So thus the percentage of evaluations that showed a resident ready to graduate in that competency. The first results I want to cover are the differences we found between the different years of residence. In general, we found that there was an increase in competency scores from first years to second years, but that leveled out between second years and third years. The highlighted row of patient care domain is pretty indicative of this, showing a 67% percentage of evaluations that met graduation standard in first years, followed by 79% in second years and leveling off to 77% in third years. Then in comparing the differences between the different residency types, we found that the hospital faculty track residents, which are represented by the white bars in these graphs, scored higher across all domains in all years than the master students and regular residents. We also found that the master students and regular residents tended to score very similarly, as evidenced by the gray and the black bars. Some discussion of these results. First, in the finding of resident type, that hospital faculty track residents score the highest in multiple domains. One potential explanation for this is that they have an extra degree before beginning residency and simply more years of clinical experience, which could have contributed to their higher scores. In the same vein, the finding that master's residents and regular residents scored similarly may be surprising, given that they are different populations of residents. However, one main similarity between these two populations is that they have the exact same years of educational background with the 5-year combined undergraduate and medical school program beforehand. The next finding from resident year, it did show that there was a jump in scores from first years to second years in all competencies, but it did also show that there were variable outcomes in the third year of residency without a notable score increase overall from the second year. One potential explanation for this is that during the third year, many of the residents were going on interviews, which may have interfered with effective evaluations. Of particular note, in our evaluations of the third year residents, 24% of the competency domain scores in the graduating class didn't meet graduation standards of a grade of 4 to 5, which seems high, but in contrast, in terms of the national qualifications, out of a class of 95 residents, 94 residents passed the national exam, qualifying them to graduate. We think that this shows some potential for the utility of this framework in that it may be identifying certain competencies or certain areas of growth that could further spur on and teach residents toward becoming effective physicians once they practice independently, things which can be achieved by, first off, identifying potential deficiencies, as well as addressing them through initiatives such as faculty advising towards these domains. Overall, this framework stands as one of the first CBME systems in place for residencies at a standardized residency program in China. This analysis shows that this framework has been successfully introduced, that attendings are able to use these evaluations to show areas in which residents can grow, and it also shows that this framework has the potential to really identify areas in which residents can better have their education supplemented and better have growth towards the areas that are essential for a quality practicing physician. There are some limitations of the study to consider. One is that there are missing evaluations overall. In terms of the monthly evaluations by attendings, about 70% of them were filled out overall throughout the year. Additionally, this is only one medical institution and a snapshot of 1 year of their evaluations. It does not follow residents longitudinally and show their individual growth. Rather, it shows different cross sections of these residents and their evaluations over 1 year. we'd like to acknowledge all those who helped us with this study. And thank you for listening, and we look forward to speaking with you all at the roundtable.
Wonderful. Thanks so much, Sean. It's great to hear so much about that project and then the evaluation piece too. Let's move on to our third presentation.
Thank you for tuning in to our hot topic presentation titled Practicing Beyond One's Scope While Working in Low and Middle Income Countries. Social Responsibility is Not Enough. Let Us Be Held Accountable. Dr. Hartman and myself are both practicing physical therapists and academics. Our clinical work concerns issues at different times in the lifespan. Dr. Hartman is an adult practitioner, while I specialize in pediatrics. However, we are brought together by our shared interest in examining the ethics and practice of global health. The context of this presentation is specifically short-term experiences in global health, or STEGs, which are experiences in which a practitioner or a student may travel over a short time span, lasting over a week to a few months. Some examples of STEGs that you might be familiar with may be international service learning experiences, where students participate as part of their educational plan, or any volunteering engagements which licensed practitioners participate in. In a survey done by Dr. Hartman and Dr. Magnuson in the physical therapy world, and this was published in 2021, in this survey, about 44% of DPT programs responded, out of which 75 reported that they were sending students abroad, totaling to over 2,300 PT students traveling annually to 60 countries, majority of which were low to middle income countries. And this is true also in the medical education field, where you can see these numbers reflecting how many medical students might travel abroad to participate in STEGs. In the physical therapy literature, the benefit narrative which justifies these global engagements is focused on the points listed here. As you may discern, these are focused on the volunteer or student. So let us keep that in mind as we proceed. Anecdotally, we've also heard from a lot of volunteers statements that are really self-focused. I appreciate that I have more, so I want to give. I find it so much rewarding to work in this situation. When I'm there, I can really do what I want. So the focus is really on the I. But there are two sides to the coin. The other being that STEGs are not without the potential for detrimental impacts. The ethical concerns surrounding STEGs have been well discoursed in the literature, highlighting the various issues which are stated here. The one we are focusing on is the potential for harm arising from one practicing outside their scope of practice or training. I'm going to highlight two studies that speak specifically to individuals practicing outside their scope. This first study was conducted by Dubey Prasad et al., who looked at healthcare providers engaging in STEGs in low to middle income countries. 49% of the respondents were asked to practice outside their scope of practice or training, of which 54% did. If you look at the table, comparing the licensed practitioner to the resident or fellow and the medical students, what is apparent here is that the least trained individual, namely the medical student, seemed to get asked in higher numbers, and 100% of these did perform outside their scope of training, highlighting the fact that the least competent person is, in this case study, or in this research paper, showed that they were the most likely to engage in practicing outside their scope of training. Here are the results of the study that Dr. Hartman and myself conducted and is pending review. 67% of the respondents believed that physical therapists practice outside their scope. So this was a survey looking at PT practitioners engaging in STEGs. 39% of the respondents felt like they were asked to engage in POSP or practicing outside their scope, and 53% did. 61% were not asked. However, 18% of those still did participate. 64.5% deemed it appropriate to practice outside their scope of practice, and I'm sharing one of the examples that a participant shared with us. Interestingly enough, when asked if they would engage in such an activity in the future, 54% reported that they would be likely to do so again. So despite all of the concerns and ethical issues surrounding STEGs, they are on the rise, and we are called to really take a look at the narrative that may be fueling this increase.
So, up to this point, we have talked about the growing trend in STEGs and how research has shown that these experiences have the potential for both beneficial and detrimental impacts. While we respect the research, we believe the beneficial narrative is the dominant one in our society, and in fact, we believe it might be flawed. Let us explain. If you go back to a few slides, you will see most of the evidence-based and anecdotal benefits highlighted were student and volunteer facing and not directed at the community or host. A recent study published in the Journal of Physical Therapy Education found that 74% of PT programs who sent students abroad collected outcomes related to various activities being performed. Of these programs, 88% of the outcomes collected were directed towards the students involved, and less than 20% were directed towards the in-country hosts and community in which these programs took place. What we are saying is actions are speaking louder than words. Research and anecdotal evidence show the primary concern for a lot of these programs and experiences are the students or the volunteers, even though most claim to be doing these programs to help or to do good. We believe this begs the question, who are these programs really for? Who is really benefiting from these experiences? Do we really know, and do we really care? Two concepts that we want to briefly talk about are social responsibility and social accountability as they relate to STEGs. As you see on this slide, one of the definitions of social responsibility is a moral principle of an organization or individual engaging in activities in order to improve the lives of others in society. Social responsibility is one of 9 core values of the PT profession. The American Physical Therapy Association has its own definition shown on this slide. Social accountability, on the other hand, is defined by WHO as the obligation of medical schools to direct their education, research, and service activities towards addressing the priority health needs of the community, region, and/or nation they have a mandate to serve. So, these definitions are similar, but let's see how they're different. The subtle difference between social responsibility and accountability is that social accountability requires educational institutions to not simply act in the interest of society, but to determine the impact of their activities on society. Social accountability is the measure of an institution's response to the societal needs, and being accountable to the people to whom the efforts are aimed to help. We feel that social responsibility movement, while intended for good, is a significant driver of STEGs, but falls short, perhaps even contributing somewhat to the detrimental impact of STEGs. Social accountability is slowly becoming a foundational tenet of medical education and practice, and we believe it needs to continue to grow and be a standard part of all STEGs, no matter the profession. We believe accountability begins with the individual. Personal accountability begins with knowledge and understanding of the legal implications of practicing in underserved communities and with vulnerable populations, especially outside the United States, and especially even more so in low middle income countries. No one listening to this talk would even think of going to your neighboring state and practicing if you don't have a license. Why would you think going outside the United States it would be permissible? Personal accountability also is knowledge and understanding of the ethical challenges that exist related to STEGs. Many resources such as commentaries, competencies, guidelines, and concept models for volunteerism and education are available. We provided a few for you here on this slide. Finally, personal accountability is unlearning your biases. Too many STEGs function within a white savior complex or neo-colonialism where volunteers foster dependency, undermine local professionals, and provide unwanted or harmful services. Knowledge generated in high-income countries often define practices and informs thinking to the detriment of knowledge systems in the community. This has to stop. Self-reflection, accountability systems, and allowing yourself, as Eva Illich said, to be surrounded by people who can tell you to go to hell when you're volunteering are all needed. While we wish we could provide you with some tangible tools, they're hard to find. A standardized tool for evaluating STEGs would be ideal, and they exist somewhat for student-facing type experiences, but the evaluation really needs to be tailored to the community needs and desires and needs to be well thought out during the planning stages. What we can direct you to is CUGH's Educational Competencies Toolkit, specifically domain number 9, competencies 9A and B. These are to plan, implement, and evaluate an evidence-based program and to apply management techniques throughout the program planning, implementation, and evaluation. This is an excellent tool with many resources, such as videos and books, on how to adequately monitor and evaluate various programs in global health. So, in conclusion, the prevalence of STEGs is likely to rise in the coming years, so we really need to critically look at what we are doing and how we are doing it. We know the volunteers and students are benefiting, but what about all the other stakeholders? Where is the accountability? Like so many things, accountability starts with understanding, awareness, self-reflection, and honesty. No more practicing outside of our scope, no more us and them, no more helping. We need to come alongside our partners in the name of health, equity, and social justice and do better. Thank you for your attention, and please feel free to reach out to myself or Dr. Delakia if you would like to continue this conversation at a later date. Thank you again.
Wonderful. Thank you so much for that fantastic presentation. Very useful for all of us who are involved in facilitating short-term experiences to sort of be thinking. Let me move on to our next presentation. I'm going to ask if somebody would mind muting. It sounds like we're getting some background noise. Sorry, hang on one second, technical difficulty.
Thank you. Good morning to everyone. I'm going to present the intercultural competencies results of a curricular reflection research project of public health and global public health competencies in the Faculty of Health Science at Universidad de Santander in Colombia. So as an introduction, during the COVID-19 pandemic crisis, the response of the institutions have not met marginalized and indigenous populations' needs, reproducing a global north view and amplifying the structural violence worldwide and in Colombia. On the other hand, indigenous organizations approached the international public health emergency with resilience and solidarity, and reciprocal exchanges rooted in ancestral knowledge, strengthening collective well-being and achieving food sovereignty, in contrast to other marginalized populations that they don't achieve food sovereignty and they couldn't satisfy their needs. So the research context is Colombia, a pluriethnic and multicultural country. We have 115 indigenous groups, almost 2 million indigenous people, almost 3 million Afro-Colombian people, and almost 3,000 Rome population. Since the 91 Constitution, it was recognized the ethnic and cultural diversity in the territory and the differential approach in health with the establishment of the intercultural indigenous health system that is not very well implemented, and they're not achieving a very good results in health because the professionals, they don't have the complete awareness of this system and the intercultural competencies. Moreover, during the COVID-19 crisis, it's important to recognize that the indigenous organizations community self-organize and they collect data to provide to the government to have their own analysis, also because the surveillance system, the epidemiological surveillance system, were not collecting data disaggregated by ethnicity, like in most countries at the beginning. So with their self-organization, they could achieve food sovereignty, achieve the collecting of the data, and meet their needs and their health needs. So in this context, we were reflecting about the global public health curriculum, and the lack of intercultural competencies to guarantee marginalized populations' rights during the COVID-19 crisis has deepened the pre-existing inequities, the pre-existing discrimination, and the pre-existing mistrust to the institutions. There are a lot of terminology in the literature, like cultural awareness, cultural respect, cultural safety, cultural understanding, culturally appropriate, cultural fluency, but we are using intercultural competencies because we think that the term intercultural that is used in the health system here in Colombia allows to connect the skills and the abilities with the system needs adaptation. So this challenging context allows us to make the reflections about the priority of these intercultural competencies in our country and worldwide. So the methodology of this research was designed by our curricular committee that we were reflecting on the competencies of the public health courses based on the competency-based education model. We made a virtual adaptation for an undergraduate public health course that addressed global health issues in the Faculty of Health Science because we needed to deliver totally virtually. So we applied to the students last year a questionnaire to assess the development of intercultural sensibility and intercultural competencies for deliver integral health interventions. That are it's the link that we are interested in analyzing. And this is the competency-based education model that we used because, and we highlighted here because we think it's very important to recognize that if we want to achieve equity in health, we need that the health professionals deliver very good interventions with leadership attributes and become change agents. And also they have to learn how to adapt to the health needs of the population, of the different populations, the different cultural and the different backgrounds populations, and adapting to the health system. So the results we got, it's that 107 participants, students of the Faculty of Health participate, mostly from physiotherapy with 37% and from medicine with 36% of the participants. Also, we have phonoaudiology, 12%, bacteriology, 7%, and less than 4% surgical instrumentation, occupational therapy, and 1% of nursing. And the results in intercultural competencies, we have that 41% of the students correctly identifies intercultural health, but only just 29% adequately correlates the intercultural health in practice and within the social determination framework. That is the link in the practical scenario that we need these students and future health professionals could apply this intercultural health in the inequity interventions. Moreover, 47% correctly address the social determinants of health framework, and just 36% recognizes the intercultural indigenous health system. So with these results, we discussed and we recognize the importance of the term of intercultural competencies, that it's we think that combines cultural and structural competencies. And even though the pluriethnic context of this research, on average, only 30% properly correlates intercultural health within practice, and these results partially explain the inequity that we have, the pre-existing inequity conditions in our health system and in the whole world, but also the lack of these important competencies in the practical scenario. We highlight that the development of intercultural competencies are fundamental for the effective implementation of integral health interventions towards equity. And also we analyze that the COVID crisis and the self-determination of the indigenous interventions, that scenario make us recognize the indigenous wisdom and their complex health thinking in an interconnected natural network, because they achieve food sovereignty with barter traditions, and also allows us to recognize that indigenous and marginalized thinking representation in political decision-making scenarios will allow the development of a decolonized planetary health and well-being. Thank you.
Wonderful. Thank you so much, Claudia. For the sake of time, I'm just going to keep moving here, so apologies.
This presentation describes the development and implementation of an online course that both the Institute of Community and Public Health in Residency University in the occupied Palestinian territory and King's College London in the UK have designed and delivered through the online platform Future Learn. This work is part of the project Research for Health in Conflict MENA region, funded by the UK Research and Innovation Global Challenge Research Fund. I was one of the developers of this course, and I taught in this course, which was delivered in February 2020 with 17 participants. 11 of them were women, 6 were men, aimed to strengthen the qualitative research capacities of mental health practitioners and researchers in the Gaza Strip. In this presentation, I'm going to talk about the rationale of this course, then a critique of the online learning, the strategies to foster plurality of voices, and then my colleague from Birzeit University, Hala, will take you through the shortcomings of our online course, the impact and future outlook. The learning objectives are to recognize the existing concern linked to online learning directed at non-Western setting to strengthen research capacity, and to identify potential strategies to foster a plurality of voices, histories, and epistemologies necessary to strengthen research capacity. The rationale for doing our course started when we identified a lack of research training among mental health practitioners and researchers in the occupied Palestinian territory. So we designed and delivered a face-to-face course on research methodology for mental health practitioners in Birzeit University in 2018. However, those who were accepted on the course from Gaza Strip were prevented from traveling from Gaza to Ramallah by the Israeli occupation. So we decided to deliver the course online to meet their needs, especially that Gaza Strip has higher need for mental health research due to the wars, violence, and human rights abuses that the people there have been subjected to for years. In designing and delivering this course, our overall aim was to advance a heterogeneous global knowledge system reflecting local contexts. Our pedagogical practice was shaped and influenced by our awareness of the inherent inequalities in global health research related to unequal access to resources, high quality training, and opportunities for knowledge dissemination. It was also informed by critical pedagogy, which exposed the domination of Western knowledge and the critique of online learning. Several scholars have identified concerns about online learning initiatives directed at non-Western settings. These included imposing Western-centric epistemology, providing unidirectional transfer of standardized knowledge, neglecting the local paradigms, culture, and expertise, reinforcing colonial legacies of knowledge production, overlooking the value of different histories and epistemologies in forming a diverse global knowledge, which results in widening social injustice. In order to destabilize hegemonic practices to knowledge generation and dissemination, we tried to create spaces for a plurality of knowledges, experiences, and histories to coexist while delivering our course. Our course lasted for 4 weeks, and during the course, we taught our learners concepts and theories of war, societal violence and health, social suffering, and the qualitative paradigms, qualitative research design, data collection, data analysis, and presenting data findings. Our delivery methods were varied, so we used articles, discussions, exercises, quizzes, videos, and tests. We were keen to adopt strategies to foster a plurality of voices, which we believe are necessary for strengthening research capacity. So we use case studies that were contextual and that were reflecting the mental health situation in Palestine and other regions such as Afghanistan and Turkey. We created dialogic open discussions, encouraging participants to share their professional and research experiences with the option to communicate in Arabic and in English. We monitored and engaged with discussions daily. We fostered multi-directional learning by regarding our learners as experts and encouraging them to link their learning to their personal experience. We encouraged participants to critique the Western adopted theories and address the relevance and applicability of Western adopted theories to local contexts, stimulating reflections and locally derived concepts. Our materials were also developed equally by King's College London and Birzeit University, and it was a result of a long-standing collaboration between these two institutions. And we addressed the locally identified need for qualitative research training among mental health practitioners and researchers. My colleague Helena will take you through the shortcomings and our vision. So thank you so much for listening.
Hello, my name is Hala Khalawi, and I am a research assistant at the Institute of Community and Public Health at Birzeit University, and I am one of the course developers and coordinators from Palestine. For my part of the presentation, I'm going to walk you through some of the shortcomings of our online course, our success journey beyond the first course run, the course impact, and finally, the future outlooks of this online learning initiative. Starting with the shortcomings of our online course, one inherent shortcoming is the lack of physical interaction, which we endeavored to overcome through creating ample opportunities for group discussions, and later in the following courses by offering weekly meetings with course educators. A specific challenge to the Gaza Strip was the regular electricity cut and poor or unstable internet connection, which we dealt with by offering downloadable materials that can be accessed on the convenience of our participants. While some participants found the course easy in a sense, others have found several new topics challenging. Some thought the course content was a heavy meal of information that needs time to digest. And I'm particularly referring to the first run of the course here. But later with the developments we've made, such as making the content less dense, offering follow-up opportunities, drop-in sessions, providing Arabic translations, learners have found the course components less challenging. Although we tried to foster the pluralistic and multi-directional learning, we are conscious that our learning material itself was not as diverse. Even though it was mostly authored by scholars from the Middle East and North Africa region, it was still heavily informed by Western approaches to knowledge, generation, and interpretation. Yet our course remains as one step towards decolonial approaches. This is just a brief summary of our success journey that began from the face-to-face course held at Birzeit University campus in 2018, where participants from Gaza were prevented from attending in person. So we then offered the online course alternative to 17 researchers and health professionals from Gaza in February 2020. And in the same year, we offered the online course to 30 participants from the Middle East and North Africa region. And our last run has just ended about 2 weeks ago. It was open to unlimited number of researchers and health professionals from across the globe. And we had over 600 people signed up for this run. For each course run, we conducted pre and post course surveys to assess learning and impact. The findings showed a tangible improvement in the participants' reported qualitative research skills. And in all 3 course runs, we received overwhelming positive feedback from participants. Learners were highly satisfied. The majority strongly agreed that the course was delivered well, the topics were covered comprehensively, examples were relevant and informative, and that the discussions were stimulating, exercises improved their learning, and the interaction with course participants expanded their knowledge. And these are some of the examples of the positive feedback we received. And I want to scroll through the online platform and show you the activity and engagement we had on the last course run. This is participants commenting and other participants responding. You can see the likes and the responses. And here is the interactions between the course participants and the educators that were answering questions and concerns. Our ambitions for this course and other similar courses is to keep working towards a future that challenges current power dynamics by fostering locally driven knowledge, production, and use. We want to see a future where locally driven research written in native language and adopting local epistemologies visible and well respected by the global academic world. We aim to build equal partnerships between academic institutions from high-income countries and low and middle-income countries as the optimum approach to ensure sustainable academic relationships and strengthen research capacities. We hope to embed multipath approaches to capture capacity changes and evaluate their sustainability and impact over medium or long term. Finally, it is important to ensure sustainability through funding, collaboration, research output, and policy impact. Thank you so much for listening, and thank you so much for having us. It was a pleasure to be speaking to you today. Thank you.
Great. Thank you so much, Nancy and Hala. And just for everyone to know that both Nancy and Hala, as well as Claudia, will be running roundtables during the last hour. So of the 5 presentations that we've had so far, 4 of them will be available to engage in roundtable discussions if you have more questions for them. Okay, so our last presentation is coming up next.
Hi, everybody. I'm Dr. Jessica Everett, the Global Medical Director of Child Family Health International. It's so great to be with CUGH at this satellite session today. You will be meeting Robin Young and some of our other team members at the roundtable, but I wanted to take the opportunity to just quickly overview some of the broad impacts of COVID-19 on global health experiential education through the CFHI experience. In terms of looking for silver linings, I do love this quote. My barn having burned down, I can now see the moon. Really taking the opportunity for the pandemic, the pause that it caused in global travel, and the opportunity to really rethink and reshape and retool our approaches to global health education. I know all of your institutions are working hard on this as well, and I hope sharing the CFHI experience is useful. So in broad strokes, what did we do during the pandemic? Well, we were very busy. We pivoted all of our place-based programs, which have now been in existence for 30 years, to virtual platforms. And so we launched a whole portfolio of virtual internships, practicums, faculty development, electives, and other courses. We restructured the organization, and I'll talk more about that. We, like we all did, we learned how to convene virtually in ways that we never imagined before. We used to do annual or even twice annual site visits to our partners in 12 countries, and this all went virtual, and we convened the entire global team in shared spaces, shared discussions, exploration, planning, and really building solidarity. We sustained financially, which was really huge, given that we are tuition-based, similar to many universities, and obviously we had to downsize our enrollment for place-based programs. And we built an online modular global health curriculum, which I'll also speak to. So CFHI generally pre-COVID would have around 1,000 students per year, and that's through individual enrollment as well as academic partners. So universities that partner with CFHI to facilitate global health experiences. And in 2021, we had 445 scholars, and you can see the breakdown here between our internships, our practicums, which are mostly designed for master's level students, faculty development, and the global health elective. In terms of frameworks, I'm not going to have a lot of time to go through many of these slides. I just have a few minutes with you, but feel free to pause at this one or any of them to look more in depth. This is just a general structure of our virtual global health internship. In terms of our elective, which is aimed at final year clinical students, medical school, allied health, nurse practitioner, APP, and clinical officers and residents. This is some of the framework that is utilized in that program. I would say, the impacts of COVID-19 on CFHI breaks down into really 5 domains: our organizational structure, our global team, program delivery and content, the impact on learners, and the impact on our commitment to diversity, equity, and inclusion. In terms of impacts on program delivery and content, we pivoted to a virtual portfolio, so taking 35 place-based programs and offering virtual versions. This really allowed us to also bring a greater focus on health systems comparatives. No longer did students only have to focus on one country because that's where they were physically located. We could really bring together our entire global team to teach in a cross-sectional way about comparative aspects of health systems, burden of disease, and other key topics. Obviously, we bolstered our online modules and the asynchronous content that we have we have a very robust pre-departure training that is online. And so that allowed us to build that out and also integrate further modular global health online material. We enhanced utilization of partnerships that we had pre-existing with Aparian Global and the CUGH group, who we partner with to teach intercultural effectiveness and humility. In terms of the tools that we use for that during the CFHI curriculum, both for place-based and virtual scholars, one is called GlobeSmart, the other is called the Intercultural Effectiveness Scale. And so these allow learners and faculty to do self-assessments and then create personal development plans and compare themselves to cultures across the world. Other impacts on program delivery and content, we retooled our competency-based curriculum and evaluation and assessment approaches. We added case-based low resource clinical reasoning in partnership with Einstein School of Medicine through Dr. Jerry Pazzioni. We added intersectoral global health seminar series, and we bolstered our planetary health content and commitment to a reduced carbon footprint. In terms of case-based low resource clinical reasoning, CFHI did not pivot to a telehealth model. I think there's a lot of concerns around the ethics, voyeurism, and quality control of trying to do any type of virtual clinical visits with students and patients in other locations, unless it's in a really thought out longitudinal and formal telehealth program. So instead of doing that and to avoid voyeurisms, we did utilize a case-based approach for replacing clinical interactions and immersion to allow students to build out their clinical reasoning in a new way. We restructured our organization and really decentralized the leadership. So I think the virtual convening space that now we're also familiar with really allows us to have increased global team leadership, partner leadership of program operations and content. We changed our nomenclature, so that's why you kind of hear me stuttering around that, but we often refer to our international teams as partners, and we really did some reflections as a entire organization across 12 countries and felt like the term partner is hierarchical in terms of calling our US-based staff a team and then our internationally based collaborators, partners. And so we changed our nomenclature and everybody is part of a global team. We downsized our US-based team and upsized our international-based leadership and virtual program operations leadership. And we had a partner-led relaunch working group with external consults to plan for relaunching place-based programs, which we currently are doing. We started relaunching place-based programs in January 2022. In terms of other impacts on our global team, it really increased the frequency, the ease, and the depth of shared spaces in the virtual platform for our entire team to connect. We do this both for team building and strengthening, collaboration, solidarity, planning, strategy, feedback, assessment, but we also do it for program content. We also expanded our invited faculty participation. So we have draw on faculty from other universities across the world and from community-based organizations to really build out the faculty we have for the virtual space. In terms of impacts on DEI, so we offered full ride scholarships to all LMIC participants in particular programs. We also launched an Hbcu scholars program, a refugee and asylee scholars program. In the virtual space, we saw our LMIC participants go from 1% in place-based programs to up to 40% in some of our virtual programs. The average over the entire organization was around 15%. So a huge growth in walking the talk of inclusion, equity, and access for learners throughout the world at all income levels. In 2020, participants in our programs drew on 6 countries, and in 2022, they drew on 22 countries. I'm confident we can continue to increase this number as we refine how we deliver on virtual content and fund scholarships and promote these opportunities across the world. As I mentioned, we went from international partners to a global team to really be inclusive in our language and appropriate in terms of global health ethics. And we developed an online global health curriculum with DEI focus in collaboration with Aparian Global. This is part of a larger online curriculum that we will be offering to university partners. So if you're interested in a kind of Global Health 101 comprehensive online course to complement your classroom learning or your experiential learning, let us know. We can talk about if you want to partner with CFHI to access that curriculum. Impacts on learners. So as you all know, CFHI is one of the leaders in competency-based global health education, particularly with an experiential focus. And so we brought these competencies, obviously, and learning objectives to the virtual space and have done research and evaluation and assessment. And I'll share a little bit of that with you, but seeing, statistically significant gains for learners in a variety of different competency domains, including cross-cultural effectiveness, planetary health, clinical reasoning, critical reflection, language acquisition, and more. Networking across 22 countries. So, when you convene students from more diverse places, there is both the formal and informal learning that happens. And I think that networking and sharing space has been a really valuable opportunity for students. Also, project-specific deliverables, these are through our practicums. So students who need to complete master's or other program requirements have been able to now do that online and complete their master's degrees on time, as opposed to not being able to fulfill graduation requirements. This is some of the data, and we have a poster. If you look at our poster, you can get more into it, and this data will be published soon. But this looks at the pre and post self-assessment scores for our global health elective. So again, these are final year clinical trainees, residents, medical students, allied health, APP, clinical officers. And so this looked at a variety of different kind of domains of competency, and you can see the competency in low resource clinical reasoning, the overall composite score, planetary health, and general global health knowledge increased in a statistically significant way. Other assessment tool that we use is a global engagement survey, and this goes through 7 scales. All of this is open access, so if you Google global engagement survey, you can learn more about it. Just a little bit of a preview of our virtual global health programs, pre and post testing in terms of cultural humility, critical reflection, increased significantly. And then, of course, I think narrative form of this assessment and evaluation that we do is student kind of testimonials. And so I'm not going to have time to read these because of this short video timeline, but I would encourage you to pause on each of these and really kind of reflect on the student's experience. I will read Ellie's words. Our conversations about ethical principles and practices have reshaped the way I think about interacting with and representing host communities. In addition, my research on adolescent pregnancy has reinforced my understanding of the impact that meaningful, comprehensive, and fair policies can have on the well-being of marginalized populations. This topic has inspired my future independent work at Princeton, as well as a future career in global health policy. This is one of the most fulfilling and transformative experiences I've ever had. I learned so much about global health and how it intersects with culture. The CFHI team was kind, helpful, and a lot of fun to work with. Ellie was one of our first virtual participants in a pilot that we did with Princeton. And, just getting this feedback and seeing that we can translate these evidence-based impacts that we've had in place-based programs for decades to the virtual space is super exciting, and I think gives us all opportunity. Enjoy your time with our CFHI team today. If you want to learn more about the variety of offerings we have, go to the website or reach out to myself, Robin, or other team members so we can talk more. Really excited to be back with you guys virtually and can't wait till we are together in person again. Take good care.
All right. Wow, that was just a fantastic set of hot topic sessions. And as I said earlier, I was loving all the conversation in the chat. I know that Diane and James have been sort of sorting through the different questions, and we have about 10 minutes or so for some live Q&A. So I'm going to turn the podium over to James and Diane. And so I don't know if you guys have a specific order, but go for it with the questions.
Awesome. Thanks so much, Tracy. Yeah, and I agree, like just a huge amount of stuff covered there, a lot of good stuff happening in the chat, and certainly can encourage people to continue putting questions into the chat. We have spotlighted Dan has helped, we've together developed a series of questions here for a couple of our presenters. And we actually wanted to open up maybe with a question first for Shreth. I think Clive unfortunately may have dropped off, but we still have Shreth, and I wanted to pose the question to him around sort of equitable partnerships. And I'll be putting the questions in the chat as I go through them as well. But since this is a CUGH conference, what are some steps that overarching organizations like CUGH can take to better support equitable partnerships across the global health field?
Thanks for the question, James. I hope I'm audible. So James, coming to your question, we need a multi-pronged approach and continued advocacy and dialogue involving donors, international NGOs, policymakers, communities, and individuals. And everyone here has a role to play, and it is time to change the dialogue into action. Now, CUGH as an overarching organization can be the facilitator, a champion, and the glue that can hold the stakeholders together in making this happen. I'll highlight some of the key steps and suggestions for CUGH, if you may. CUGH can lobby with international NGOs to focus on a transition mindset, where there's a clear plan in place for milestones for the transfer of power and resources to local organizations. CUGH can also advocate with donors to reevaluate partnerships with local organizations so that they're more equitable and the donors and the recipients are equally mutually held accountable based on realistic indicators that we talked about earlier. CUGH can also engage with policymakers in host countries to push the donors to involve local communities in decision making and let the communities set the agenda. And lastly, through the CUGH communities, subcommittees, and the working groups, the presentations that we heard earlier, organize and connect to networks and groups that support this agenda and make a push for change. As one of the participants in the chat box mentioned, if we don't say it, we can't change it. So yes, as an overarching organization, these are the things CUGH can do to facilitate change. Back to you, James.
Excellent. Thanks so much, Shreth. I think a very cogent and focused response there. I'm taking notes on it because I think these may be a topic for us to delve back into as CUGH is a large organization. So I appreciate it very much, both for the audience and for myself. Next question is going to be for Jeff and Kripa. And this is just a question about, and following up on their presentation on STIGs, thinking a bit about what are tangible ways that STIGs can be made accountable by eliminating the likelihood that students are asked or to act inappropriately by hosts.
Want to start, or I can kick us off. Couple thoughts. One is the
from my experience, students want to do things right, and they want to do things ethically in a responsible way. But I think a lot of it is not understanding these ethical challenges and risks that are associated with these STEGs. They really think they're going to do good. And I think it starts with that pre-departure training. I think it really starts with requiring that the training and those in-depth conversations about what are the risks associated with what we're doing, and really emphasizing the fact that they're learners and they're going to learn first. And having those conversations, in my experience, students are very receptive to those conversations and kind of reframing what the role they're playing in these experiences. And then on the ground, I think it's really having those clearly agreed upon defined roles of who the students are and what their responsibility is. And again, emphasizing the fact that they're learners first, and having the local community accept that and embrace that role, I think is important too. So having those clearly defined roles.
Yeah, I just want to jump in and add to that, in that I think always looking at the entirety of the project in terms of pre-departure training, the implementation, but also what happens afterwards, giving students the time to really critically reflect on their experience. And I have to agree that being very transparent that these are students, they're not competent practitioners yet, and being very clear about that. And I can speak from experiences that I have, because we are doctors of physical therapy. So when we go somewhere, the community typically thinks that we're medical providers and can ask us to do things that are not outside our scope of training. So being very clear about who we are. And I love Dr. Everett's saying about don't just do something, stand there, is very much, what we need to promote, I think, when we talk with students, and empowering them to say, no, right? I am not trained to do this. It becomes very important. And they get a chance to really learn from the indigenous knowledge, which I think is very powerful for their learning.
Excellent. Thank you both. I think, and nice job there too, Krupa. I think there's a lot of intertwining themes here that cut across some of our presentations. And I particularly like that question for y'all, just because I think so many of us work with students, at least those of us based in the HICs, work with students who are doing STIGs or things along those lines. So trying to make sure we do them best. I'm going to pass it to Diane for the other two questions.
Thanks so much, James. Our next question is for Robin and Gonzalo at CFHI. And the question is, it's so great to see you use the pandemic as a pivot point, as many of us have, in evolving your programs. What do you expect will happen as travel opens up again and a quote unquote return of circumstances similar to the pre-pandemic era?
Thank you, Gonzalo. Maybe I'll start and then just interrupt me or jump in. So I think there are a few different things that we're seeing, because we have reopened some of our place-based experiential programs. We're doing so really thoughtfully, and Gonzalo is actually one of the co-chairs of our internal risk assessment group, helping to work together to determine how and where we can safely reopen place-based programs. So it's been really important for us to think about that and begin to do that. We are seeing continued interest in virtual learning, both from our university partners as well as individual students. I think in her presentation, Jessica highlighted really effectively the opportunities that virtual programs represent for students that we weren't effectively reaching before through place-based global health educational opportunities. So as she highlighted, we're seeing a lot of students from around the world who may not have been able to access travel-based opportunities. We're seeing students in the United States who are choosing virtual opportunities, either because they have really lockstep programs and travel is not an option for them. They may be international students studying in the US and there are visa constraints. Many students have financial restraints that would be really prohibitive, and travel-based programs just are not feasible. So we are still seeing sort of that hybrid demand, I think, for programs. So of course, at CFHI, we are noting a pent-up demand for travel-based experiences as well. I think also we're thinking a lot on our team about thinking about our global team, what is the ecosystem and what are the roles that we can each play in terms of supporting our team as a global team. We know that a lot of the risk management aspect and sort of the expectations of universities around student safety and wellness are things that on the US side, we can help to support our global team to understand and be prepared for and do, team-wide capacity building to make sure that we're all really well versed in the protocols and the expectations and even the compliance and legal aspects of those questions. Whereas our teams, around the world, our teams in Bolivia, as Gonzalo is, and Ghana and Uganda and elsewhere, really lead the programming and the curriculum development. And those are also ongoing discussions as a team. One last thing, and Gonzalo, I would love to hear from you too. I think we've also thought about a sort of a spectrum of approaches, or a spectrum-based approach where many students we're finding are interested in starting virtual and thinking of the virtual opportunity in some ways as an extended pre-departure experience. And then actually having the opportunity through our virtual programs to build relationships with the leadership in Uganda or Ghana and really learn about all of those foundations, the determinants of health, thinking about honing their competencies, understanding the local health system in a little bit more of a theoretical manner, and then having the opportunity after that really robust, perhaps month-long virtual opportunity at some point to go on and have a place-based experience. So those are some different things we've been thinking about. And Gonzalo, I don't know if there's anything you would add to that.
Yeah, well, not really, Robin. I think that you and Jessica, showed CFHI, very clearly, but something we really value here at CFHI is the fact that we are becoming more inclusive. Right, because we are reaching out to populations, as Robin said, that were not financially able to participate in our programs before, because we know that traveling is costly, because you're thinking about raising costs and tickets and visas and home stays and a lot of other components of the programs that some students find hard to pay. That's one thing. So we are reaching out to them and they are taking our virtual programs. That's one thing. The second thing is that because of job constraints, they have to work. They are in their masters and they are taking their masters and working part-time. They don't have the luxury. They cannot afford the luxury of, international travel. So we have the opportunity of practicums. That is really important. Another interesting thing is that all our programs are really local, right? The local teams are developing the programs for students or with the students together, right? So we are, in that sense, also being part of this decolonizing process that we have been discussing throughout some of the presentations here, right? So we are not we're not going to a program with our solution, with our program. This is what we want to do. This is what we want to cooperate with. We are going to accommodate to whatever you have. We think that is a lot more valuable, and it is very enriching for both the local team and the student or students that are participating in that program. And of course, as Robin said, something that we're also seeing is the tendency to these hybrid programs where students take virtual and then they move to the in-person programs, or they take both. We are working on that kind of design right now, where they do part virtually and part in person. So it comes profitable. It is something that could be paid, and it's something that is inclusive. So it is interesting. We are working very hard, with the local teams. That's something we learned from the pandemic, right? We have a more open dialogue now. Before we had like a managerial kind of relationship, but now we have an open discussion, and now we have this global team where everybody participates and everybody gives ideas. So that is really interesting. And of course, training components, we had to learn a lot, we had to pivot and we had to learn a lot. So that's what we did. And we just learned a lot of new skills that are, improving our work every day. So yeah, that's what we're doing, and we're very happy about it.
Thank you both for sharing how intentional the program is going to move forward. And it's not just a return to the basics of before, but the intentionality of hybrid programs and open dialogue. And on the note of open dialogue and equitable partnerships, this next question is for Hala. Would you share your reflections on the partnership between Birzeit University and King's College London in light of the discussions we're having about equitable partnerships?
Hello, everyone. I would like to talk about the long-standing relationship between the Institute of Community and Public Health in Birzeit University in Palestine and the Global Health and Social Medicine, the Department of Global Health and Social Medicine at King's College London. It is a long-standing relationship and a collaboration of more than 10 years. We have been working on several research projects. The projects are led by Dr. Hannah Kinsler at King's College London and Dr. Riam Hamoudeh and Dr. Rita Jakaman from the Institute of Community and Public Health. And they were several projects about different research topics. And this course was an outcome of this longstanding relationship and the need of like building more capacities in the occupied Palestinian territories and of course like decolonizing Western research methodologies. And I'm not sure if Nancy has anything else that she probably can talk about because she was more involved in this longstanding relationship than I was.
Hi, everyone. It's nice to see you all. Thank you, Hala. Yeah, as you mentioned, it is a long-standing collaboration between King's College London and our department, Global Health and Social Medicine. And this was basically led by Dr. Hannah Kinsler with her relation and connection with the Institute of Community Public Health in Birzeit University, led by Dr. Rita, Professor Rita and Dr. Hannah, and they, Dr. Riam, sorry. And they have done lots of projects on ground addressing a mental health need in Palestine. So they have several other projects as well that have been running for a long time. And as Hala mentioned, this is the outcome of a long-standing collaboration. And it was based on a need assessment that was done on the ground among health professionals in Palestine to address their needs for research training, especially for those who are working in the mental health field.
Very good. Thank you so much, Nancy and Hala, for sharing your experience with that partnership. Thank you to all of our hot topic discussion speakers. I'm going to check in with our co-host here. Do we have time for that little break to stretch our legs?
We definitely do. Thanks, Dan. Yeah. So I think everybody, like, you can take 5 minutes, but a very, very firm 5 minutes to, stretch your legs, use the restroom, get tea, coffee, what have you. Whatever is the appropriate beverage for the time of day that you're in. When you come back, we'll be breaking into the roundtables. So we'll put up a slide detailing all the different roundtable groups, and people can assign themselves into roundtables. And then we'll have about 40 minutes in those discussion groups before we come back and hear a bit of a report back from them. So everybody, 5-minute break. We'll reconvene at, for me, 12:10 Eastern time.
Okay, welcome back from the break, everyone. I think we should go ahead and get started just because I know we're going to be bumping up against our sort of end time in just 50 minutes here. So James and I had a chance to just confer during the break. I think what we're going to do is 35 minutes for the discussion so that we have enough time for a report back so that, every group will be able to share a little bit about what they discussed with the larger group. So just to put up the slide to show you what the different options are going to be. So I put the names of the different roundtable discussion groups in the chat, but here it is on the larger screen. So our graduate medical education working group is going to be joining the list. They'll be our first discussion group. And then our trainee advisory committee will also be joining, doing a session on building student connections. A group from the Medical College of Wisconsin, headed by Ashley Pavlik, will be leading a discussion on their GME-wide global health enrichment curriculum. And then as far as our presenters from earlier in the morning, you'll see that we have the session on undergraduate intercultural competencies in a multi-ethnic country, the session on decolonizing research methods training with respect to locally responsive online learning, for researchers and practitioners in the Gaza Strip. We have the session on clinical performance evaluations of resident physicians in China, the group on virtual global health education, impacts on learners, organizations, and equity. And then last but not least, our 8th session will be on building equitable partnerships with the capacity development of Indigenous organizations for equitable and effective development collaborations. So the names of the breakout rooms are listed. Please select whichever you'd like to join. For our facilitators, if you do not have more than one of you in your group, please select somebody to take notes on the Google Slides. We've created this Google Slide framework to make it easier for everyone to share during the report back piece. So we'll just have everybody, if you can take notes onto that slide, just limit the notes because we only will have about 2 minutes for each group to share during that session. So with that, I will stop sharing and invite you to select the breakout rooms. And then again, it'll be about 35 minutes. So we will see you back here around, 12:45 Eastern or 9:45 Pacific. Thanks so much.
Yeah, so I think for the debriefing, we were just going to have each group, you get sort of 2 minutes to briefly reflect a little bit on themes that came out of this. I think we appreciate that this is it's an exercise in sort of turning 30 minutes of intellectual discussion into a very brief period. So do the best you can. We also appreciate that the length of time for roundtable is not really enough to get deep into anything, but hopefully our goal is that it's going to whet appetites, it's going to make some new connections, and maybe for some folks it provides some new resources and new thought on projects that you're pushing forward. So that's kind of what we're targeting with the experience, as well as trying to maintain some increased level of interactivity in a virtual format. So I think once Tracy gets the slides up, we'll just have whoever would care to from each group kind of share a little bit with us. And so I think we'll start here with Jenny and Sharon. If Sharon is on.
All right, Jenny, would you like me to, let's see, or would you? You're muted.
I defer to you, Sharon.
Okay. All right. Well, we had a really good discussion with some people we hadn't met before, so it was actually really nice to hear from other people around the country. And actually, we'll have to connect later, but I think our curriculum is very similar to the one in a couple slides coming up here in terms of a GME curriculum. But some things that we discussed were we just brought up some good points that we do need to ensure that the curriculum is not too, quote unquote, Northern centric, needing to make sure that there's enough focus on emphasizing teamwork with our local resources and contacts, and, how the difficulty of how do we actually teach cultural humility, how do we ensure really bi-directional education, and really emphasizing learning that's on the ground and in the field. And so some thoughts on how do we get feedback from really our LMICs to know, what is it that they want us to know. We talked about how, really our curriculum is really meant to be a broad set of learning objectives that can be adaptable depending on the specialty, depending on the site that the residents may be going to and the institution. And also a good point that the curriculum should probably be adaptable to or applicable to some of our local, global, and community settings, especially as people are not traveling as much with the pandemic. Those are really the big things. Jenny, do you want to add anything else? Thank you.
Awesome, cool. Thanks so much, Sharon and Jenny. I appreciate it. Under time, under budget, perfect. So next up, we have Deepika. I think there may have been a dearth of trainees here, if I remember correctly. But Deepika, I think
Hi, James. Yeah, so we unfortunately didn't have any participants for the roundtable, but I put together some takeaways just based on earlier, listening to the hot topics and the discussion that went on in the chat as it relates to student connections. So one of the takeaways was that peer-to-peer networking is really important, a really important way to improve cultural competency and gain understanding of educational systems outside of our own. I think a lot of emphasis for us as students and trainees are placed on sort of developing those mentorship relationships and finding a mentor, someone who's already in the professional field. But I think encouraging student-to-student networking is also really important, because eventually we'll become professional colleagues, and it helps to foster that sort of collaborative setting, as well as start to learn from one another pretty early on without those geographic barriers that we would otherwise face. And that's something that we do here on TAC as well. And with our campus representatives program, I think some of the hot topics also talked about sort of reflecting on the ethical implications of student global health experiences. And I think that's something that students can reflect on together in the hopes of improving that those experiences for the future. And just since there are no resources shared, just one of the events that we have coming up, I don't know if there are any students or trainees here today, but to sort of further foster building peer-to-peer connections, we have a couple of events coming up throughout the conference. And if you want to learn more about TAC and our campus representatives program, you can reach out to myself or Elizabeth, who's the incoming TAC chair.
Excellent. Thank you so much, Deepika, and thanks again for your work as the TAC chair all year. And yeah, if there are any trainees on the call, please do connect with the TAC. They're a great resource and a great space to be part of. All right, so next up we have Ashley.
Yes, we just talked about a 2-year GME-wide global health curriculum that we started at Medical College of Wisconsin 2 years ago. We talked about sort of the couple of years of planning that went into it, doing sort of needs assessment of what our residents were interested in, and then also looking at the other similar programs that are already in existence. Our model is briefly outlined here. We have a 2-year program. We're in our second cohort now. It's about 1 hour once a month, and then we have a couple times a year sort of deeper dive experiences. We try to make it really easy for our residents to participate in. It's all virtual. It usually happens in the evenings when they can, after they've come home from their work, and we're very welcoming to families, etc. And we've been getting some good feedback so far, and then we've also had some feedback from them on some other directions that they want to take it, including, what we anticipate global health will look like for them, taking into account how the COVID pandemic has changed the way that we do global health going forward. Some of the references in there are just our Office of Global Health. We're lucky to have a very robust Office of Global Health that helps operate this program, and we had some questions afterwards about our global partnerships, etc. So that's a website there.
Excellent, great. Thanks so much, Ashley.
I think there weren't any participants in this session, so I'm going to skip to the next one.
Okay. And then I think we have Nancy and Halala on decolonizing research methods.
Yep. Hi, everyone. So the main points, so we discussed multiple points. Actually, we had enough time to discuss a lot of things. So the first thing we were asked about is we started off our discussion with how the origin of this course happened. So what was the spark to do this work? And as we mentioned earlier, it was the result of a long-standing relationship between King's College London in the UK and Birzeit University in Palestine. This course happened following a needs assessment that was done on the ground with people interested in research methods in mental health. And we inquired about their needs, and they said that they needed a training, and after doing a training in research methods in mental health. And we have also done research that also reflected a need of qualitative and quantitative research methods in mental health. So this is where the spark and the origin or the history behind this course. So we were also asked on why we chose mental health and whether it was because it's our specialty, but it was not the reason why we chose mental health. The reason why we chose mental health to focus our course on is that it is one of the areas that we have. So we have an umbrella of research being done among the two institutions, and one of the areas was mental health. And of course, by doing our research, we found that mental health research is needed in conflict areas, or in conflict areas, and is needed due to the suffering of Palestinians under the Israeli occupation. And we found that we need to equip health researchers in this area of expertise. And professionals have mentioned in the needs assessment that they have a lot of data, they've collected a lot of data, there's a lot to talk about in mental health and mental illnesses, and they did not know, they were never directed, never guided on how to use this data and reflect it on research. So we needed to produce a training that people can use the data they collected under these circumstances.
Excellent. Thanks so much, Hala. And my apologies. I think just in the interest of time, I will have to cut it off at that, but people can still look at the slide, and we'll put the remainder of the slides into the chat as well.
Sure,
thank you so much. Appreciate it. All right. And then Sean, I don't know if there are any reflections you want to offer up briefly on this?
Yes, I'd like to just quickly wrap up our project with some reflections regarding this competency-based framework that has now been established at a hospital in China. I think some key ideas we wanted to talk about were the importance of letting Indigenous ideas drive the creation of these new frameworks. There's definitely a lot of great competency-based frameworks out there, but through the process of making this framework and basically asking for the opinions of what makes a quality physician from, physicians, nurses, staff, and admin, there's definitely some key differences in the tenets of this framework than ones that have been established in other countries, which we think is a really good feature of this. Another is just in this collaboration of University of Chicago with this hospital, did this sort of drive to not be prescriptive, to be helpful collaborators, but not necessarily just to prescribe what is better. And then just wanted to talk about as well some challenges in these ideas. I think it's not always that easy to necessarily implement. For example, for letting these Indigenous ideas drive the creation of the frameworks, I think that the tenets are very specific to what the stakeholders at that hospital want, but at the same time, in creating the milestones, the main milestones that are available are not from China, but from other countries. So there was just sort of this combination, of those two frameworks that happened in the end. And just it's all in the work that we're doing. But yeah, thank you guys.
Awesome. Oh, thanks so much, John. Appreciate it. Next up, we have, I believe, the CFHI group. So Robin or Gonzalo.
So I think I had agreed to share out after Beth helped us with notes, realizing we're very short on time. We were excited about the collaboration and the teams that spanned geographies in a way that was cost savings and allowed us to repurpose travel funds in new ways, enhancing the diversity of our faculty and participants. We recognize the drawbacks, scheduling and imposing on someone's evening or early morning, which remained a challenge. And in looking forward, we want to find ways to do things better, to bookend virtual relationships with live interactions, if possible, and also to recognize the value of moving from being more abstract to the reality of immersing yourself in a setting and being more active. There are a couple of links shared, and I will stop there. Thank you.
Awesome. Thank you very much. Yeah, great. And then I think our last group. Great. Yeah, Ms. Clavion and Seth on the building equitable partnerships. So whoever's reporting back for them.
Thanks, James. I'll briefly share our discussion. So we had a really passionate group and very diverse, and we ran short of time, so we couldn't finish our planned discussions. But here are some of the key points. We started a discussion on what are the aspects that are missing in the definition and discussion around building equitable partnership, community-centric, putting community first. That was something that came up, accountability to each other. And we had discussions around power and history of of partnerships. We discussed that we do need a dialogue around measuring equitable partnerships and how to evaluate that the partnerships are equitable. At University of Washington, Department of Global Health, we do have some of the examples, and if we had more time, we would have gotten more into it. But Chi Chi is a great resource, and she'll be able to share some of the experiences we've had across the network. Another discussion was on what can be done to actively and realistically work to dismantle some of these macro level equity issues. We discussed the honest conversations around currency conversation and curriculum is required. We didn't get time to get into useful references. There's a global aid report, a decolonizing aid report that we generally find useful around the discussions. So we can share that, and then the contacts there for further discussions. Back to you, James.
Thanks so much. That's great, and I think and a very wonderful end to a wonderful conference. So I think Tracy's put into the chat our evaluation form. As educators, we love feedback, and every year we're trying to refine this and improve it. So if you can take just 2 minutes, we've made it very brief, but it really does have a great impact. I just want to quickly thank both all the presenters. I think a lot of excellent topics from our subcommittee chairs and working group chairs to the hot topics to now our roundtable organizers and speakers. And then also, of course, thanking our organizers for the actual satellite conference itself. So Diane, Iris Blom, and then also Sylvia Callender, I think maybe off at this point, all sort of helped work over the last several months to get our presentations organized, to get our people who were get our submissions evaluated, and generally work through things as well. And then also thank you to Charles from Confex, who's been doing tech support, and to our CUGH organizers who are always getting our back, especially Dalal and Denise Steinbach. And then Tracy, pass it to you for a second.
Sure. No, I know that we're already over time, so just wanted to thank everybody for sharing this space with us today. This is, I think, always one of the most inspiring 3 to 4 hours that I spend every year thinking about global health education and getting a chance to connect with all of you. And I really hope that there are some new ideas that will come out of this and some new connections that will come out of this that will advance your educational endeavors at your own institutions. We'll be sharing all of these materials with the list of folks who registered, so don't worry about that piece. And just to say finally, as this year brings the end of James and my term as the co-chairs of the Education Committee. So we look forward to staying on and supporting the new chairs, but just want to thank everybody for all of your hard work to move forward so many of these wonderful initiatives over these last few years.
Yeah, and just echo that last point. Thank you, everybody. It's been a really great time, great 2 years working as co-chairs. And I think in particular, as we're very appropriately spending a lot of time reflecting on how to improve global health and improve our systems, it is nice also to reflect just on the really powerful community of people interested in health we have across the globe, very nicely represented here, and to reflect too on the positive work that we're doing as a community. So we look forward to helping everybody move that forward over the years to come.
Thank you
so much.